Hello, my name is Gianni Atherosclerotic, a Senior House Officer at the Leicester Royal Infirmary. Welcome to this 5-minute presentation on cardiovascular disease caused by atherosclerosis. I will discuss the pathophysiology of atherosclerotic disease and risk factors which are important for understanding preventative measures, management and treatment strategies. The two latter topics will be covered in an additional presentation. Cardiovascular disease is a leading cause of death worldwide and covers a wide range of conditions, with atherosclerosis being implicated as a cause for the vast majority. The consequence of atherosclerotic plaque formation and/or rupture is by far the most common cause of cardiovascular disease, for example the acute coronary syndromes and also cerebrovascular disease from transient ischemic attacks to ischemic strokes. This diagram illustrates atherosclerotic development, which can be defined as a complex inflammatory process characterized by lipid and macrophage-rich plaque formation as a consequence of endothelial arterial wall injury. Many factors can damage the arterial lining, from shear mechanical stresses, for example turbulent blood flow caused by hypertension or at sites of arterial bifurcations, to biochemical and immunological factors. Following endothelial damage, there is increased permeability of the vessel wall to plasma proteins, predominantly lipoproteins, into the intima. Macrophages then engulf the lipoproteins and form lipid-laden foam cells, which are seen as fatty streaks. With cytokine release and further migration and proliferation of macrophages and smooth muscle cells, a growing fibrolipid plaque forms. With plaque progression, any further damage to the lumen causes platelet aggregation and thrombus formation, and as blood pools into the ruptured plaque it becomes unstable, growing in size to reduce vessel circumference. When the diameter of the lumen is halved, hemodynamically significant stenosis occurs, which causes ischemia with increased oxygen demand. Total occlusion results in infarction distally. Unstable plaques can also rupture and form emboli at distant sites. Atherosclerosis is inevitable as we age, and the pathological process occurs in all from early adult life. However, if we recognise the factors that contribute to its development, we can appreciate ways in which to slow progression. The main modifiable risk factors include hypertension, smoking, cholesterol and diabetes, but of course the factors we cannot influence are increasing age, male gender, family history and genetic composition. There are many causes of primary hyperlipidemias which can be defined broadly according to the lipid derangement of combined hyperlipidemias, hypercholesterolemia and hypertriglyceridemias. Non-specific physical manifestations may include xanthelasma. The most common form is familial combined hyperlipidemia, manifesting as high low-density lipoproteins and high triglyceride levels, causing suppression of high-density lipoproteins, leading to increased cardiovascular risk. Primary hypercholesterolemia is an autosomal dominant disorder which can be hetero or homozygous, with the latter presenting with ischemic heart disease in childhood and death occurring in adolescence. The defective gene causes underproduction of LDL cholesterol receptor in the liver, and pathological tendon xanthomas are seen. It is important to be aware of these conditions because understanding their etiology will help direct treatment. Prevention is better than cure, and therefore addressing modifiable risk factors is very important because progressive disease can be fatal if not grossly disabling. Patient education plays a huge part in this because their understanding of the health implications of their actions may help to influence lifestyle choices and helps reduce risk. Pharmacological interventions such as antihypertensives, antidiabetic medications and lipid-lowering therapy are of course valuable, but lifestyle modifications are often the first-line approach. Encouragement of a low salt, low saturated fat, healthy, well-balanced diet along with exercise can reduce blood pressure, cholesterol and blood sugars. Stopping smoking is one of the best health protective steps overall that patients can take. And specifically, smoking almost doubles the likelihood of having an MI compared to age-matched non-smokers because of the toxic nicotine, tobacco, and carbon monoxide, which, as well as causing endothelial injury, increase strain on the heart through mediating adrenaline release. It has to be remembered that stopping smoking can be a very difficult task for patients, and where possible, appropriate support should be offered, for example, nicotine replacement. In summary, understanding how and why atherosclerosis develops is important in being able to reduce cardiovascular disease risk. For those that have already developed a significant degree of disease, addressing modifiable risk factors is still crucial, but pharmacological management and/or invasive therapies may be required to treat or at least manage cardiovascular disease caused by atherosclerosis.
In 1901, Augusta was taken to an insane asylum in Frankfurt, Germany by her husband. She was described as a delusional, forgetful, disoriented woman who could no longer carry out her homemaking duties. She was seen by a Dr. Alzheimer, and was to become the case that made his a household name. On autopsy, he described the plaques and tangles in her brain that would go on to characterize the disease, but lost in the excitement of discovering a new entity, a clue may have been overlooked. He described arteriosclerotic changes, hardening of the arteries within her brain. We typically think of atherosclerosis in the heart, but atherosclerosis involves virtually the entire human organism, our entire vascular tree. And one of the most poignant examples of the systemic nature is the link between coronary artery disease, degenerative brain disease, and dementia. Back in the 70s, the concept of cardiogenic dementia was proposed. Dementia generated from the cardiovascular system. Since the aging brain is highly sensitive to lack of oxygen, since heart problems are so common, it was easy to imagine that's how dementia could result. And now we have a substantial body of evidence that strongly associates atherosclerotic vascular disease with the number one cause of dementia, Alzheimer's disease. Autopsy studies, for example, have shown that individuals with Alzheimer's disease have significantly more atherosclerotic narrowing of the arteries within their brain. This is what our cerebral arteries should look like: open, clean, allowing blood to flow. This is what atherosclerosis in our brain arteries looks like: clogged with fat and cholesterol, closing off the arteries, restricting blood flow to our brain. What kind of brain arteries do you want in your head? Normal resting cerebral blood flow. The amount of blood flow circulating within our brains is about a quart a minute, but we lose about 0.5% a year, so by age 65 we may be down 15–20%, but this doesn't necessarily affect brain function as we have a built-in buffer. However, this age-related decline in cerebral blood flow can become critical to brain cell survival if an additional burden further lowers that flow. This reduction of blood flow can starve the brain of oxygen, cause silent little mini-strokes, brain atrophy, shrinkage, the cumulative effects of which appear to play a pivotal role in accelerating and augmenting the development and evolution of Alzheimer's disease. If you look at the amount of atherosclerosis in the arteries that specifically supply blood to critical memory and learning centers of the brain, this is the amount of severe atherosclerosis one sees in healthy, non-demented controls, compared to those with Alzheimer's disease. In light of such findings, some have even suggested the disease be reclassified as a vascular disorder. This is good news, though, because atherosclerosis is potentially reversible. These findings were confirmed in 2 larger studies, over 1,000 autopsies each, which found the same thing: atherosclerosis in the brain is significantly more frequent and severe in those with Alzheimer's disease. This suggests that strategies proven to delay the progression of artery disease, like plant-based diets, may be useful in preventing or treating Alzheimer's disease. Of course, autopsy studies are a little late for that, so to assess the impact of intracranial arterial narrowing on the progression from mild cognitive impairment to Alzheimer's disease, researchers followed 400 folks with cognitive impairment for 4 years, using CT angiography, special CAT scans, to evaluate the amount of brain artery blockage. The cognition of those with the least atherosclerosis in their heads remained pretty stable over the years, but those with more cholesterol buildup got worse, and those with the most blockage rapidly declined. And the same with the ability to carry out activities of daily living. And it doubled the progression to full-blown Alzheimer's disease. An inefficient blood supply to the brain has very grave consequences on brain function. But does treatment of vascular risk factors like high blood pressure and high cholesterol actually make a difference? We didn't know until now. 300 patients with Alzheimer's, and those with all their vascular risk factors treated showed significantly less decline, less kind of slowed progression of their disease than those who went untreated. It is said that the goal of medicine is to provide patients with hope, and when there is no hope, with understanding. Well, for the first time in the history of this disorder, we have the chance to provide Alzheimer's patients with hope.